Professor Kreitner, are you ready?
Yes, I'm ready.
Well, in that case, welcome everyone and thank you for joining us at today's webinar, Imaging of Pulmonary Hypertension, What You Need to Know. With us today is Professor Karl Friedrich Kreitner. He's a professor at the Department of Diagnostic and Interventional Radiology at the Johannes Gutenberg University of Mainz in Germany, where he also completed his undergraduate training as well as his residencies in diagnostic radiology and radiotherapy. He is a visiting professor at the University of Toronto and at McMaster's University, Hamilton, Ontario, Canada, and at the University of Zurich, Switzerland. Professor Kreitner has published over 200 publications in peer-reviewed journals and has written several book chapters. He serves a number of international radiological committees and acts as a reviewer of several journals. His cardiothoracic research interests include the assessment of CTEPH by MR and MDCT imaging techniques, qualitative and quantitative assessment of pulmonary perfusion, and the assessment of pulmonary hemodynamics. So welcome and enjoy. Also, in case you have questions, please feel free to use the chat function.
Okay, so thanks for this kind introduction. I hope you can hear me. And now I want to start with my presentation on imaging of pulmonary hypertension, what you need to know. Before we start with this topic, I just want to point out some pathophysiological aspects. The pulmonary vascular bed is a low-pressure, low-resistance system. In pulmonary hypertension, we have an elevation of the arterial pressure and the vascular resistance chronically, and they finally lead to an impairment of the right ventricular function in forms of right ventricular dilatation and hypertrophy. Clinically, we can discriminate three phases of pulmonary hypertension: an asymptomatic period where the increase in pressure and resistance are compensated, and then the symptomatic decompensation, and finally the advanced decompensated clinical phase. If you are looking at this scheme, you can well imagine, as far as if you're looking at the duration of these clinical phases, that it might last a very long time till the diagnosis of a pulmonary hypertension is made. And this is due till today, and I think before this background, imaging gets a really important position in detecting those patients suffering from the disease. Now, how is pulmonary hypertension defined? The definition is quite easy. It's defined as a resting mean pulmonary arterial pressure of 25 millimeters Hg or above this value as assessed by right heart catheterization. This definition makes it clear that till today, for the final definition or for the final diagnosis, all patients should have to undergo a right heart catheterization. It was the World Health Organization that organized a meeting in Dana Point in 2008 where they built a classification system. This classification system aimed to group together different entities with similarities in pathophysiology, clinical presentation, and therapeutic approaches. This classification system is still under continuous evaluation, and the last workup has been done in Nice in 2013 with a nearly unchanged grouping of these different entities. For pulmonary hypertension, we can discriminate 5 disease groups, beginning with the pulmonary arterial hypertension that might be idiopathic, heritable, HIV-related, CTD-related, that means connective tissue diseases, portal hypertension, congenital heart disease, and schistosomiasis. The group 2 is mainly due to diseases of the left heart, and it is in clinical reality the most important or the most numerous group of patients who develop pulmonary hypertension due to left heart disease. The third group are related to diseases that affects the lung, mainly COPD and interstitial lung diseases. The fourth group is very interesting because this deals with some form of chronic thromboembolic disease, and the most important issue in this case is that this is the only form of pulmonary hypertension that may be cured by a very complex operation. And in group 5 we have different entities that are grouped together, for example storage diseases or sarcoidosis or myeloproliferative diseases. So if you're looking a little bit more into pathophysiology, you can distinguish two kinds of pulmonary hypertension. Pulmonary hypertension with an elevated pulmonary wedge pressure. This is mainly due to diseases of the left heart, but also belonging diseases from the first group, namely pulmonary veno-occlusive disease and pulmonary hemangiomatosis. These two disease entities, they are characterized by an elevated pulmonary wedge pressure, and all other disease entities going along with pulmonary hypertension, they have a normal or a pulmonary wedge pressure below 15 millimeters Hg. If you're looking at the estimated prevalences, everybody thinks that pulmonary hypertension is a rare disease. And I must confess that in fact this is not the case. Why is this the case? Because our population gets older, and I think this is the reason why we can find pulmonary hypertension up to 10 or 20% of the general population, because with increasing age we have an increasing number of patients suffering from left heart disease. And if you're looking at the subgroups, it's very clear that, for example, idiopathic pulmonary arterial hypertension is relatively rare. On the other side, in advanced cases of chronic obstructive pulmonary disease or in interstitial lung disease, the number of patients with pulmonary hypertension is relatively high. And we all know that survivors of acute pulmonary embolism, they have a risk of about 2.5 to 4% of developing a chronic form, also leading to pulmonary hypertension. And in the last group, the prevalences are unclear in multifactorial pulmonary hypertension. So the challenges for imaging and the challenges for us as radiologists, they are fivefold. We have to detect pulmonary hypertension with a high accuracy. We have to characterize the underlying disease. We also have to quantify the extent of pulmonary hypertension. That means we have to assess right ventricular size and function, perfusion characteristics, stiffness of the pulmonary arteries, pulsatility indices, the decoupling with left ventricular function and also the impairment of the left ventricle. And finally, and what's most important, is the determination of the mean pulmonary arterial pressure, the pulmonary vascular resistance, and the transpulmonic pressure gradient. And what would be ideal is if we had imaging modalities available that allow us for monitoring of the therapy and also that have some prognostic value for the individual patient. If you are looking at the recent published guidelines on diagnosis and therapy of pulmonary hypertension from a radiological point of view, this is very disappointing. Why is this the case? Because if you're looking at these points, cross-sectional imaging modalities like CT are relatively sparse. CT gets a class 1 level C indication in the diagnostic workup of patients with chronic thromboembolic pulmonary hypertension, and it is recommended, it's only recommended as a high-resolution CTs in patients, in all patients with pulmonary hypertension for the assessment of lung parenchyma. I think this is very disappointing at the moment, and I will try to show us in how far we could in future add really important information in those patients suffering from pulmonary hypertension. And this is the reason why I in my talk want to focus on multidetector CT and MR imaging, because these are they are very robust techniques, and they allow not only morphologic imaging for the assessment of lung parenchyma and the pulmonary vessels, but also they are functional imaging techniques. And this is not only true for MR imaging, which is basically a functional imaging technique, but also with newer CT techniques, especially with perfusion CT, what we now call spectral CT. I think there are studies coming up showing us that this might be very, very important and might be replacing, for example, VQ scanning in the next future. And I also want to show you later on in how far we can get with phase contrast imaging, and in its latest variant, the 4D phase contrast MR imaging techniques. Going back to our challenges, the detection of pulmonary hypertension, and you can see from simple CT data sets, and you can remark on simple CT data sets whether a pulmonary hypertension is present or not. I just give you some marks which have a relatively high sensitivity and specificity in the diagnosis of pulmonary hypertension. Just take a look at the diameter of the main pulmonary artery, or do not forget to compare the main pulmonary artery to the ascending aorta. If this is greater 1, well, you have a high sensitivity in detecting pulmonary hypertension in case you don't have an aneurysmal disease of the ascending aorta. Or just look at the segmental or lobar arteries, the right descending pulmonary artery and also the left descending pulmonary arteries. Again, here you can discern hints that a patient suffers from pulmonary hypertension. And please do not forget to take a look at the cardiac of the right ventricle of the heart. If the free walls, if the diameter of the free walls exceeds 6 millimeters, you have a high diagnostic accuracy in detecting or in diagnosing pulmonary hypertension. And if you have a ECG-gated, retrospectively ECG-gated CT dataset, you can also take a look at the cross-sectional area of the right pulmonary artery at the different cardiac phases, and you can get some, well, cutoff values where you can also detect with a high accuracy pulmonary hypertension. Just here an example from the work from Mary Rebel, which was published in Radiology, where you can also make a circle on the right pulmonary artery, and if you see here, if it is below 16.5%, then the probability that a patient suffers from pulmonary hypertension is very high. And these are the characteristic images you get from your CT datasets. Take a look at the main pulmonary artery. In case it exceeds the diameter of the ascending aorta, think of the presence of pulmonary arterial hypertension, or just take a look at the lobar arteries and their relation to the bronchi. Again, if there is an exceeding diameter, then please do think of the presence of pulmonary hypertension. And you can also take many measurements in your CT datasets, and you can see that you get highly significant results. And of course, we should always take a look at the heart. Look at the diameter just on axial images, just as we know it from acute pulmonary embolism. Just take a look at the diameter of the right ventricle in comparison to the left ventricle, or take a look at the free wall of the right ventricle. If it exceeds 6 millimeters, then the patient suffers from pulmonary hypertension. And in this patient, you again have an excessive dilatation of the main pulmonary artery. And of course, due to the increase in pressure of the right heart, you have a backflow, a reflux of contrast in the liver veins to a degree that is not normal. Again, this is a hint. If you just take a look below the diaphragm, where you can see, well, this patient must suffer from pulmonary hypertension. And this is also true if you take just MR metrics from cine imaging. You can look at the muscle mass and at the relation between the muscular mass of the right ventricle in relation to that of the left ventricle, and you get also really good values in detection of pulmonary hypertension. And if you are using, for example, late gadolinium enhancement, look at the junction of the right ventricle to the left ventricle. When you have enhancement, this strongly correlates with the presence of an increased mean pulmonary arterial pressure. So this is an example in a 20-year-old female with pulmonary arterial hypertension due to connective tissue disease, so she belongs to group 1. You can also nicely see the paradoxical movement of the interventricular septum. You see a decoupling of the action of the right and the left ventricle, and look at this tremendous increased hypertrophy of the right ventricular myocardial tissue. So this is a classical finding in a patient with pulmonary hypertension. You can also try to quantify the muscular mass and set it in relation to the left ventricular mass. And if you're doing late enhancement imaging, look at these hinge points where you have an enhancement, and this also correlates with the presence of an increased pressure. And the last patient in this respect is a young patient with an uncorrected tetralogy of Fellow, where you can see the overriding aorta, and you see also here he has a right ventricular hypertrophy. He's 26 years old, he's non-corrected. You see a classical pulmonary arterial angiogram with an exceeding over the prominent main pulmonary artery, and in this case we also performed late enhancement imaging, and you can nicely depict areas with increased contrast uptake indicating fibrosis of the right ventricular tissue. So for characterization of the underlying disease, well, I already pointed out that HRCT or MDCT is the imaging modality of choice, but please think of the fact if you're dealing with younger patients and for follow-up studies, it is also possible to use MR imaging for this purpose, which can be summarized as short TE imaging, which helps you also to detect especially interstitial fibrous diseases that compare very well with CT imaging. And of course both MR and CT allow the assessment of the pulmonary macro and micro circulation, where I think that ECG-gated MD-CTPA is clearly superior to contrast-enhanced MRI, and perfusion imaging is possible by both imaging modalities. I'm going on to this later on. Just some examples showing interstitial lung disease with CT, but it can be also depicted by MR in fibrosis and also in COPD. So you should keep this in mind, that perhaps for follow-up studies and in younger patients it might be useful or sensible to use MR instead of CT, just for reducing radiation exposure to radiation. As far as the assessment of the macro circulation is concerned, I already pointed out that ECG-gated MD-CTPA, I think, is currently the standard for assessment of the pulmonary arteries. And for this regard, it is very essential to look in patients if there is a form present that we call chronic thromboembolic pulmonary hypertension. The reason is this is a form of pulmonary hypertension that can be cured by an operation. So MD-CTPA, I think, is capable to make the diagnosis and also the differential diagnosis, and also to make some to assess the technical operability in the individual patient. And we already pointed out that it performs better than contrast-enhanced MRA. And I think what we now can conclude from the present data, here are some newer work added, that a negative MD-CTPA scan precludes a surgically accessible form of CTEPH. I think this is very important, and with this in mind, it can also compete with VQ scanning. Just some examples going from MR imaging. Here a patient with a chronic thromboembolic pulmonary hypertension. You see the occlusion of the left lower lobe. You see the webs and bands that have to be worked out in multiplanar reformats, and this is the classical appearance of a young patient with an idiopathic pulmonary arterial hypertension, where you have the centrally enlarged arteries and this pronounced reduction of the caliber of the peripheral pulmonary arteries. And if you are going further into details, here you can see the webs and bands, the remnants of this organized thromboembolic material in CTEPH. And on the other side, if you're doing a high-resolution CT, this is an examination we performed around 20 years ago. So you can imagine how all these MR images might be. You see here the typical corkscrew-like appearance of the peripheral pulmonary arteries indicating pulmonary hypertension. And coming to ECG-gated MD-CTPA, I'm very well convinced that we can better assess the proximal extent of the central organized thromboembolic material much better than with selective DSA, but this information is very crucial for the operator because he now knows where to begin with his dissection plane for this pulmonary endarterectomy. And this is from a study we performed where we are convinced that CT is the best method to delineate the central beginning of the organized thromboembolic material. You can also see it on MR, but it is better depicted by CT and much better than by DSA imaging, only indirect, and here we can see it directly in the vasculature. And finally, I just want to show you a young patient where it was not so clear whether she has a idiopathic pulmonary arterial hypertension or CTEPH, but if you take a look at these segmental and subsegmental arteries, you see some irregularities. So we came across that she might have a CTEPH, and we were very interested to see what is going on in the lung parenchyma. You see here a typical mosaic perfusion pattern, which we do not expect in patients with idiopathic pulmonary arterial hypertension. And if you're taking a closer look at the lung tissue, you see peripheral infarcts, indicating that there might have been some embolic events leading to this infarction of the pulmonary parenchyma, and then we came along that we have a form of subsegmental CTEPH not considered to be operable in a multidisciplinary CTEPH team. Coming to the assessment of lung tissue perfusion, you have two imaging modalities available. The first is certainly MR. We now have available acquisitions with a temporal resolution of around 1 second, so you can acquire a 3D data set every 1 second at the expense of your spatial resolution, but to assess wedge-shaped perfusion defects, this is completely sufficient, and there is only one study available, however, with more than 100 patients where we have a high sensitivity and specificity in the detection of CTEPH, and in this study the performance was comparable with VQ scanning and MR perfusion imaging is no surgical treatable form of chronic thromboembolic pulmonary hypertension. We need more studies like this for, well, for establishing MR in future guidelines as far as the diagnosis of pulmonary hypertension is concerned. I just want to show you two examples from our own files where you can also use this imaging technique in the differentiation between pulmonary arterial hypertension and CTEPH, where we have a more homogeneous finding in pulmonary arterial hypertension with a prolonged mean transit time. We have no wedge-shaped perfusion defects, and these are the data in a patient with CTEPH. This is contrast-enhanced MRA for macrocirculation, and here are the regional blood volume and blood flow and mean transit time based on this sagittal acquisition, where you can see we used here a relatively low amount of contrast just for performing an absolute quantification of lung perfusion. This is something not ready for clinical routine, but you can nicely depict this wedge-shaped perfusion defects in this patient with CTEPH, and also the different imaging pattern or the different finding pattern in comparison with idiopathic pulmonary arterial hypertension. What's coming more and more into clinical routine is the ability of performing spectral CTs, either as dual energy CTs, or you have the possibility with acquisition of data sets at different KVs, so that you can calculate or that you can compute iodine maps. These iodine maps may be a surrogate parameter for tissue perfusion. I must confess that this warrants further basic research in how far we can postulate it, but what we can see in our clinical setting, this works, and it may be of great help, especially in detecting CTEPH patients. And there are now some studies available where we could show that that with this technique, all CTEPH patients may be diagnosed by spectral or dual energy CTs, and therefore this technique also may play a role in the diagnostic workup of these patients. This is a dual energy CT data set which I owe to Professor Johnson from Munich, where you nicely can depict this wedge-shaped perfusion defects in the periphery in a patient with a more peripheral form of chronic thromboembolic pulmonary hypertension. And these data sets should only show you the difference between CTEPH and idiopathic pulmonary arterial hypertension, where you nicely see here these wedge-shaped perfusion defects, and in idiopathic pulmonary arterial hypertension you have more a homogeneous distribution of lung perfusion. So coming to the last point of my talk is the assessment of pulmonary hemodynamics. I think this is presumably only possible non-invasively with MR imaging with respect to the estimation of the mean pulmonary arterial pressure and pulmonary vascular resistance. There are some papers available where they made a combination of cine and phase contrast MR imaging, but I think the future will lie in phase contrast imaging, and not only in 2D flow, but I think especially in 4D flow. I just want to point out two studies that have been done in the field. We performed a relatively small study. It was a validation study in 19 patients with CTEPH, where we invasively recorded the mean pulmonary arterial pressure by a Swan-Ganz catheter in the main pulmonary artery, and we made our phase contrast measurements, and we created some regression equation where we could relatively exactly determine the mean pulmonary arterial pressure. If you're looking here, this is in the same range as Gettreiter was available in his large study in patients with suspected pulmonary hypertension, and in comparison with right heart catheterization, where the standard deviation is really very, very low, and he achieved an accuracy of more than 90% in assessment of the severity of pulmonary hypertension. Now, what is going on with 4D flow? Well, you can do an analysis of flow in all directions, and this temporarily resolved, and the increase in pressure in the pulmonary arterial system leads to the creation of vortices, and these vortices they have a different time duration, and obviously this time duration correlates very well with the increase in mean pulmonary arterial pressure. And from this latest work, he sent me these images where he can nicely analyze not only the flow in the pulmonary arterial system, but also he can analyze the acceleration index in the left atrium. This is the basis for determination of the pulmonary wedge pressure, and from the transpulmonary gradient he is able to calculate also the pulmonary vascular resistance. And if you're looking at these correlation values, this is very, very promising, and in my eyes, if we have more studies and perhaps multi-center studies available with correlation to right heart catheterization, I think we will be able in the next future to determine the severity of pulmonary hypertension non-invasively, and only in questionable cases there will be a need for right heart catheterization. What is currently under investigation? Well, based on 2D and 4D flow, there are many working groups focusing on pulse wave velocities and pulmonary arterial stiffness, because with these data we get some insights into the pathophysiology of pulmonary hypertension. We can assess by wall shear stress. We have insights in the amount of stiffening of the vessel and the reduction of the Windkessel effect in these cases. And if we can assess these findings, we can also monitor or document the influence of modern drugs leading to an improvement of the hemodynamic situation in the individual patient. But this is currently under investigation. Taking a look at prognostic significance, there are also some works available that show us that the simple assessment of right heart function by cine-MRI allows us to determine values that have prognostic significance. For example, right ventricular end diastolic volume index, or the stroke volume index, and also the left ventricular end diastolic volume index. They had been the strongest predictors of mortality in patients with idiopathic PH, and the ejection fraction is very, very important, and basically it's relatively easy to determine. And also, if you're taking a look at the cross-sectional diameter of the main pulmonary artery, you can also make some prognosis on patients with a more favorable and a more worse outcome in their further follow-up. And in this respect, there has been appeared a meta-analysis where all these parameters were weighed against each other, and the most important thing is right ventricular ejection fraction is the strongest predictor of mortality in patients with pulmonary hypertension. Just a few words in the end of my talk regarding the monitoring of therapy. This is best evaluated in patients with CTEPH. These are those patients that undergo a pulmonary end arterectomy, and in case of a successful operation, these patients return to a nearly normal life. And it's very interesting to see that within 2 weeks after a successful operation, you can well, see reverse remodeling, and also what holds true is with a tremendous improvement of the right ventricular ejection fraction, which also has a prognostic significance. You can see a decrease of the right ventricle. You also see a decrease, interestingly, of the right ventricular mass. You see an increase of the right ventricular ejection fraction. You see a normalization of septal bowing, and there have been many, many studies available in this field. This is the same patient I already showed to you. This is the same patient 2 weeks after successful PEA. There is a nearly complete normalization of the pulmonary arterial vasculature. Well, there are some risks, but pulmonary hemodynamics return to normal. And this is the same patient with a cine imaging in the 4-chamber view, where you can see this tremendous reduction in size of the right ventricle. There is no paradoxical movement of the interventricular septum. This is very, very, very impressive, and I think for monitoring of the disease and for monitoring of the success of the therapy, MR imaging is very, very convenient. So if we put all those things together, and if we want to weigh out the importance of CT and MR, I think both are equivalent in detecting the presence of pulmonary hypertension. I think CT is better than MR in the assessment of the lung parenchyma. With the assessment of macro and microcirculation, there are some advantages for CT, especially for macro circulation for the large vessels. For perfusion imaging, I think both are equivalent, but we don't have the corresponding studies available at the moment. For the assessment of right heart impairment and pulmonary hemodynamics, I would favor MR imaging, also for monitoring of the therapy and also for prognostic significance. So if we conclude, we can say that CT and MR address multiple aspects in patients with pulmonary hypertension. The combination of morphologic and functional imaging reveals important findings with regard to detection, assessment of disease severity and prognosis. And I think in this respect they outperform tremendously, for example, echocardiography, which is still regarded as the first step in the diagnostic workup of patients with pulmonary hypertension. However, we must confess that large-scale, prospective and multi-center studies are still lacking. And furthermore, the pathophysiological assessment, especially with MR imaging, will provide further insights in the disease entities. And only then, when we have done our homework, we can expect that we have a tremendous impact on updated guidelines on the diagnosis of pulmonary hypertension. And with this, I want to thank you all for your audience and wish you a nice evening. Thank you very much for your attendance.
Thank you very much, Professor Kreitner. So to the audience, in case you have any questions, please feel free to use the raise hand button or type your questions in the chat box. In the meantime, I'd like to announce that our next webinar will be on April 12th on approaching dilated hearts. Is it only a matter of tissue characterization? Speaker will be Charles Peebles from the UK. So let's see if anyone has any questions. So far not, Professor Kreitner. It seems you did a great job.
Oh, well, I think it's not the great job. I think it's, well, not so usual that you are dealing in your clinical routine with pulmonary hypertension. So, but I hope that it's worth looking at our CT data sets that you depict those patients that have pulmonary hypertension, because the clinical presentation is so unspecific, and this is the reason why there is a considerable delay between the onset of symptoms and the final diagnosis.
We have one question coming in from Gloria. She wants to know, in which patients exactly do you choose to perform MRI?
Um, well, if we want to, I perform MRI nearly in every patient with pulmonary hypertension, especially if we want to assess non-invasively, get some information about the mean pulmonary arterial pressure. I think this works very well with MR, even with 2D imaging. So it's not necessary that you have a 4D imaging package available with a considerable amount of post-processing time. Well, I think this is the most important reason. And if you are doing MR imaging, do not forget to do perfusion imaging just for detection of patients which suffer from chronic thromboembolic pulmonary hypertension, because these patients, they are potential candidates for a, life threat, for life-saving and life-saving therapy in these cases.
Okay, we also have a second question from Maya. This one is, should ECG gating also be used for a pulmonary CTA in patients with acute pulmonary embolism?
This is a very good question. This is something still under discussion. I personally prefer ECG gating in even in patients with suspected acute pulmonary embolism, because I have the impression that the assessment of smaller vessels is better than in patients without any ECG triggering. But this is not a fact of current guidelines. This is my personal experience. There are still data lacking showing us that this really enhances the diagnostic accuracy, especially in the detection of subsegmental PE.